Well, welcome everyone to the Rose Award winning platform presentation. I'd like to first introduce the Academy of Orthopedics Rose Award winner. This is Linda Van Dillen and her co-authors, Dr. Lanier, Karen May, Michael Wallendorf, Barbara Norton, Jesse Civello, Sylvia Czuppon, Sara Francois, Kristen Rolls, and Catherine Lang. And the title of the study is The Effect of Motor Skill Training in Functional Activities versus Strength and Flexibility Exercise on Function in People with Low Back Pain. So we're super excited to have Linda here to present. I'd like to first start with a little bit of background with regards to the Rose Award. So Steve Rose was a member of the Academy of Orthopedic PT. Then it was the orthopedic section of the APTA until his untimely death in 1989. Steve advocated for the use of research to investigate the theories for the basis of our practice and to determine the effectiveness of what we do. He challenged all those around him to think clearly. He saw power in knowledge. His life was cut short with unfinished deeds. He chose not to consider the limitations of today, but the possibilities of tomorrow. Dr. Rose would be proud of the progress we've made in the demonstration of the efficacy and effectiveness of our practice. But he would encourage us to continue our research as he encouraged continued growth and change. Steve challenged us with a life worth living. So with that, no further ado, I'd like to pass the mic to Linda Van Dillen, the winner of the Rose Award.
Thanks, Amy. Thanks for the introduction. Before I start the formal part of the presentation, let me see if I can move back here. There we go. I wanted to thank the Academy for the special recognition as the recipient of the Rose Excellence Research Award. It really means a lot to our group to be recognized by everyone in the Academy for the work that we've been conducting over the last several years to complete this project. We were very, very surprised, but we are truly honored to have gotten this award. I asked Amy if I could also say a few words about Steve. I wanted to talk about him because I knew him both professionally as well as personally. I worked with Dr. Rose. Steve hired me into my first clinical position. He put me in the division of neuromedicine and neurosurgery. And it was there that I learned a lot about the importance of movement to physical therapy practice. I also realized that perhaps the prognosis for improving movement might be better in patients that didn't have neurological dysfunction. And hence I decided to study people who had musculoskeletal pain conditions. I'd have to say that the day I was hired by Dr. Rose, my whole career trajectory was changed in ways that I could never have imagined. And he taught me a lot of things. For the sake of time, I'm going to mention three key messages that have stayed with me across my research career. And the first is to always pursue the truth. The second is to continually question the work that's in the literature. And the third, and I think most importantly, is to continually question my own work. And that's what our group has tried to do over the years. In fact, I didn't even really believe a lot of the findings we had until about 8 to 10 years into our research program, when we started to replicate findings and other people started to replicate the findings as well. So thanks very much for this opportunity to present to all of you. I think I feel very lucky to be able to present to this really important audience. So thanks. So I'm going to move on to the formal part of the talk now. And again, we're going to talk about a clinical trial that we recently published in JAMA Neurology. And so I'm going to talk a little bit, give you some background information about back pain conditions and some of the details about back pain that we got really interested in pursuing and have been pursuing over the last several years. I'm going to talk about a conceptual model that we've been testing the assumptions of for most of my research career. And I'm going to highlight the prior findings, a couple of those from those tests of assumptions that really set the stage for conducting this clinical trial. And then the trial, I'll talk about the specifics of the design and the results, and hopefully highlight the relevance of these findings to clinical practice. So our overall objective in our research program is to understand the movement system contributions to musculoskeletal pain conditions, really to provide a solid foundation for the development and testing of interventions. And with the goal of the interventions to have two purposes: one, to improve the clinical course of the condition by way of active rehabilitation, but also in developing maintenance and self-management programs for these conditions. And the third goal, or the second goal, is to hopefully develop interventions to prevent the condition. So one really important detail or fact about nonspecific low back pain, which is the focus of this trial, is, and that has driven a lot of our questions, is this idea that the course of nonspecific back pain for many people is recurrent, fluctuating, or persistent pain and limitations. And so what you see here on the left is a graph of pain intensity on the y-axis and time on the x-axis. And this shows you 5 simplified trajectory patterns of pain, but this could also be of functional limitations related to a person's back pain condition. And this is from Alice Kongsted's group, who published this in 2016. And what they did is looked at studies of individual patient trajectories of back pain after an acute episode. And what they identified is 5 different patterns. I'm going to briefly go through those so that you can understand kind of why we've pursued the questions we have. So the first pattern is one that we're all familiar with. This is one where somebody has an acute episode, they have a lot of pain and limitations, and then they get over the episode, whether they have intervention or not. And this is something that was predominant in the literature with regard to the course of low back pain. And people would have an acute episode, get over it, go along, and perhaps have another episode. And the thought was that these were unrelated to each other. The second pattern that they've identified is a delayed recovery pattern. So you have acute low back pain, and instead of getting over it pretty quickly, it takes time. They have pain and limitations over several weeks, but eventually they recover. The third pattern is one of ongoing, fluctuating, moderate pain. So you have the acute episode, and then the symptoms and the limitations kind of go up and down, and this persists over time. And then the last 2 trajectories that she's identified across studies is one of persistent back pain, either moderate pain that is associated with the episode and then just continues, or persistent severe pain. So those are the 5 different patterns. And then the other thing just to note is that, as we know, for most people who have acute back pain episode, almost everyone, or at least there's a very high likelihood of many of those people having a recurrence of low back pain. So the idea is that we don't know exactly how long it takes for a recurrence, but a large proportion of people will have this. And so this was particularly interesting to us and has driven a lot of our questions, because we want to understand the factors that contribute to this course. So because there's many people who don't have this rapid recovery, what are the variables that contribute to these different patterns of pain and limitations? So why don't people solve the problem, basically? And are there modifiable factors that we can use during intervention to change that course of the problem? So there's 2 qualifications of this presentation before I get into the details that I want to highlight. And the first is that this, I'm really highlighting the role of the sensory and the motor system to the course of back pain and how you might treat it. Here you see a radar plot that this was proposed by Peter O'Sullivan, and he showed that there were 8 proposed domains that may contribute to what somebody looks like when you see them in the clinic. And these dark lines show you the predominance of the factors that are contributing to what that person looks like. Again, I'm going to be focusing on the sensory and the physical or motor factors that are predominant in most of the people we see and how you might treat them. The other qualification is that focus here is on people who have nociception as an important contributor to the back pain presentation. So we all know that there's 3 pain mechanisms that can contribute to what someone looks like when you examine them. Again, these people that I'll be talking about have a predominant nociceptive picture. And we identify this by way of validated self-reports and then our standardized history and clinical tests. So I'm going to talk about the kinesiopathologic model very briefly. This is a conceptual model that was proposed by a colleague of mine, Dr. Shirley Sarman, a number of years ago. And I got interested in testing the assumptions of this model to determine whether it was valid or not. And so this model describes processes that are proposed to contribute to both the development as well as the course of musculoskeletal pain conditions. And again, today I'll be talking about the model as it applies to non-specific low back pain, which was this type of patients that we treated in this clinical trial. And I'm going to highlight findings from a few of the studies where we've tested these assumptions, again, because they lead to this clinical trial that we just published. And the idea of testing the assumptions, again, is to determine whether or not this model is valid. And if it is, then that would provide a rational or a logical basis for treatment of people with nonspecific low back pain. And this is particularly important in a condition that doesn't have a specific diagnosis that drives how you would treat them. So if the model is valid, then it gives you targets for treatment. So I'm going to just show you a figure that outlines the processes that are proposed to contribute to nonspecific low back pain based on this kinesiopathologic model. And so the idea is that repetition of movements and postures of the lumbar region, typically in the same direction, during daily functional activities is an important contributor to the development and/or the course of someone's low back pain. And similar to therapeutic exercise, where you use it repetitively to get adaptations, the proposal is that the repetition of daily functional activities actually contributes to adaptations as well, and specifically to the musculoskeletal and the neural system. And so I've shown you here some of the proposed adaptations, such as changes in strength or joint flexibility, or changes in timing of activation of muscles and recruitment patterns of muscles. And so the idea is that you get adaptations that are ongoing because of the repetitive nature of your functional activities. These are playing off of each other, and eventually these adaptations develop into impairment. So changes in or alterations of function and physiology. And of course, we know that people with nonspecific chronic low back pain have impairments of strength, flexibility, activation, and recruitment patterns. Well, the model really takes it a step farther and says, not only do you have these impairments, but the impairments work together to contribute to adoption of altered patterns of movements and postures. So impairment patterns that become over time generalized across several activities. So you may develop these patterns with a repetitive activity you do on a regular basis, but then the pattern gets generalized across everything that you're doing, or many things you're doing, so that it's learned activities. And we know that generalization is important in learning, but in this case, it actually could have a negative impact. And so the specific alteration that's proposed based on this model to contribute to low back pain is that the lumbar region becomes relatively more flexible, or it moves more readily than other joints such as thoracic spine, the hips, the knees, and/or the ankle. And it's also proposed that these specific impairment patterns can be identified during clinical tests that you'll perform during an examination, as well as during functional activities that people are reporting are limited due to their low back pain. The repeated use of these specific impairment patterns contributes to altered loading, accumulation of localized areas of tissue stress and irritation that result in back pain and back pain related limitations, as well as tissue injury at the micro and the macro level. And then finally, it's proposed that until these patterns during daily activities are modified so that they look more like back healthy people, the person's course of low back pain will continue. And I've shown you that there's a number of different courses other than rapid recovery that could characterize a person's back pain, back pain course. So I'm going to show you an example, just so you know what I'm talking about. For anybody who's seen me give this talk before, you've seen these clips, they're classic. On the left is a clinical test that we do during our examination, just to show you what the impairment pattern looks like. Basically, Dr. Sarman here is moving the person passively, and then they'll move actively. And what you'd expect is minimal to no motion of the lumbopelvic region in the early part of the hip, but you see just the opposite here. Almost as soon as she starts to rotate her hip, you see lumbopelvic rotation, and this would be an impairment pattern. On the right is the same participant now performing a functional activity of gait. And you'd expect to see about 4 degrees of pelvic rotation during swing. And you see early and excessive lumbopelvic rotation with the swing phase. And this is proposed to be because the lumbopelvic relatively more flexible into rotation than the stance hip does into hip extension. So I'm going to again describe some studies that we've conducted prior to the trial. And just so you know who we're talking about, it's a specific subset of people with non-specific low back pain. And the characteristics are listed here for you. So this is what you want to think about is to whether or not you would apply the findings from this study into your own clinical practice. So the mean age of people in our studies is around 40 years of age. They have chronic non-specific back pain. We define chronic low back pain as function limiting symptoms that are present greater than half the days in a 12-month period. It's non-specific if there's no direct relationship between the person's presentation and specific pathophysiology or pathoanatomy. They're not in an acute flare-up, and that's purposeful. We really want to see what are the characteristic movements and postures that people are using that they say are limited because of their back pain condition. So it's not confounded by the acute flare-up. They have minimal to moderate levels of pain and limitation in function, minimal to moderate levels of activity, relatively low levels of fear avoidance on the FABQ questionnaire, and average mental health scores based on this short form 36 questionnaire. So now I'm going to talk about clinical and functional activity tests that we use both in our laboratory studies as well as our clinical studies. And I'm going to highlight some of the prior findings from these studies that led to our clinical trial. So the first important finding from these studies is that there are differences in the extent of the impairment patterns between people with and without low back pain, such that people with low back pain show a greater number of impairments as well as a greater magnitude of impairment patterns compared to people without low back pain, which would suggest, because people with low back pain look different from those without, that perhaps these impairment patterns are important to the condition. We've also identified that people with back pain display a consistent type of impairment, such as rotation and lateral bending, flexion or extension patterns across tests. So they're generalizing the impairment pattern definitely during our clinical tests. We've also identified this across some functional activities that people report as problematic. We have also found that the type of impairments that people display on clinical tests is related to the type of activity that the person is participating in repetitively. So a nice example is a person who plays a sport on a regular basis that where they may rotate and laterally bend to one side. If that person has back pain, they then will show impairments related to rotation and lateral bending that are associated with their symptoms. A fourth very important finding is not just that people who have back pain look different than people without low back pain with regard to the impairment patterns, but also that those impairment patterns are related to the person's back pain symptoms as well as the functional limitations they're reporting. So this is true during functional activity tests as well as clinical tests. During clinical tests, if the person shows an impairment pattern that increases their symptoms and you systematically modify it and the symptoms get better, then it's associated. And we see that both with clinical and functional activity tests. In terms of functional limitations, we know that the greater the magnitude of the impairment pattern, the greater the functional limitations that the person is reporting. So again, it gives some relevance to the impairments that we're identifying. And finally, there's differences in the types and numbers of impairments among people with non-specific back pain. So not just that they're different to back healthy controls, but also among people with low back pain, we can actually subgroup or phenotype them based on the predominant type of impairment pattern that we see on clinical tests and the symptom behavior that increases with the impairment, and then the impairment is systematically modified and the symptoms improve, then that tells you that the impairment is relevant, and you can subgroup the patient based on the predominance of those impairments. So together, we think that these findings supported a role for movement as an important contributor to back pain presentation. And so our next step was to test an intervention targeting impairments, particularly during functional activities. So I'm going to talk about an earlier phase 2 clinical trial where we looked at subgroup specific versus non-specific treatment. I'm going to talk at a very high level about this because it does set us up for our recent clinical trial. So the primary purpose of this study was to test efficacy of subgroup specific treatment versus non-specific, with the idea that if you can subgroup people based on impairment patterns, and if you target that, you may get an enhancement in your outcomes compared to a general treatment. However, another important secondary purpose was to test the moderating effect of adherence on outcomes. And we got interested in adherence because, of course, adherence should enhance outcomes. And in fact, when we conducted a pilot study, we found that people who were given a multimodal treatment, which is very typical of physical therapy practice, actually adhered differentially to the different components of treatment. And in fact, people adhered to exercise for a short period of time, but continued to adhere to changing how they were performing their functional activities for a much more prolonged period of time. So we decided that we would look at adherence, but look at adherence to the different components of treatment, because adhering to different components could contribute to differences in outcomes. So the treatment components in this early trial were the same, but the details differed. And so the components for both conditions were education, exercise, and training and performance of functional activities. In the subgroup specific condition, the treatments were directed towards the person's specific impairment patterns that they displayed on clinical tests. In the non-specific condition, they got education about the positive course of back pain, strength and flexibility, and then training to perform functional activities based on basic biomechanical principles. So our primary outcome for this trial, as well as the subsequent trial, is based on looking at function. And we use the Modified Oswestry Disability Questionnaire as our primary outcome. And this is because function is the primary reason that people seek medical care for their initial back pain episode, as well as subsequent episodes. And we used an intention to treat analysis for these, for the Modified Oswestry Disability Questionnaire scores. So this is the data for the efficacy aim of this study. And the take home is that the change in function based on Oswestry over time was the same for the subgroup specific group and the non-specific treatment groups. And so I'll walk you through this data. On the y-axis is modified Oswestry, and on the x-axis is time. And what you see in gray is the active treatment phase. And the first thing to notice is at the beginning, people have a score of about 22%, which is a minimal to moderate level of functional limitation. The next thing to see is that both groups improved 30%, which is a clinically important amount of improvement on the Oswestry. And that was true for the non-specific group and for the specific group. We measured people out to 6 months, and people interestingly gained another 35% improvement on their Oswestry scores for a total improvement of 65% at 6 months. From 6 to 12 months, there was a 20% regression or a 45% improvement overall, but the improvement was the same for the two treatment groups. We did, as I said, measure adherence. So we looked at adherence levels over time and also the moderating effect of the two types of adherence. So overall, exercise adherence dropped off more and at a faster rate than did adherence to functional activity performance. And this was true for both groups. So I've collapsed the data for the two treatment groups. And so you see adherence on the y-axis and time on the x-axis. And again, here's the active treatment period. This is the data for functional activity adherence, and this is for exercise. And so exercise dropped off 40% over the study period, and functional activity adherence dropped off 15%. So a difference in the amount and rate of change. Interestingly, during the active treatment phase, people were reporting that they were significantly dropping off in their adherence to the kind of traditional exercise while increasing their adherence to performance in functional activities. The exercise adherence continued to drop off significantly across the subsequent 12 months, whereas functional activity adherence did not drop off until the last 6 months. So similar to the pattern you saw in the Oswestry scores that I showed you just a moment ago. In terms of moderating, we looked at both types of adherence and whether they moderated functions. So these are Venn diagrams to show you Oswestry scores and adherence to exercise and adherence to function. And the overlap shows you that indeed Oswestry scores and exercise adherence are directly related, as well as Oswestry's and adherence to function. So the more the person adhered, the better their Oswestry scores and vice versa. However, the size of the relationship between function or Oswestry scores and the two types of adherence differ such that the size of the relationship was larger for adherence to function than it was to adherence to exercise. And if you took into consideration the adherence to function and adherence to exercise in the same analysis to see if they had independent effects, what we found is that exercise adherence did not have a significant relationship that was separate from functional activity adherence. So here you see Oswestry scores again and the overlap of exercise adherence, indicating there's a relationship between the two. But you see that adherence to function explains the same amount as adherence to exercise, but also explains an additional unique and independent amount of Oswestry scores. So whatever you get from adherence to exercise, you get from adherence to function, and you get even more in terms of explaining changes in functional limitations. So these data suggested that people benefited from changing how they performed functional activities, and they did it more and they did it longer than they did the traditional exercise component of the treatment. So this suggested to us that specific training and functional activity performance may be important to improving the person's current pain and limitations, but also the course of the low back pain, because people continued to improve in the first 6 months while they were continuing to adhere to their functional activity training. However, this study has two limitations. The first is that the effects were a combination of the traditional exercise and training and performance of functional activities for both treatment conditions. So individuals in both conditions were adhering to varying amounts to both components of treatment. So we really don't know how much the training was driving the change versus the exercise was driving change. The second limitation is that we didn't implement principles that would facilitate learning, which may be the reason for the amount of time it took to improve. In this study, it was 6 months, and also the regression in the effects after 6 months when people started to not adhere as much to both exercise as well as functional activity training. So this suggested to us that if we optimize the conditions, the effects could be larger and more long-lasting. So this led us to this recent trial of motor skill training versus strength and flexibility exercise in people with chronic non-specific low back pain. So on the left is the design of this study, and I'll walk you through that. And on the right are the goals of this particular clinical trial based on all of the findings that I just outlined for you. So we brought people into the laboratory, and we got self-report surveys and laboratory measures of movement. We then randomized them to one of two different treatments. It was either strength and flexibility exercise or what we're calling now motor skill training. And this was with the goal of trying to disentangle the effects of exercise and training and functional activities that we had in the prior trial. So we were separating those effects to see their independent contributions to change in function. We also wanted to maximize the effect of training and functional activities by way of the delivery. And so the delivery in the skill training was no longer just practice, but rather it was driven by motor learning principles in an effort to increase the rate of improvement as well as getting a durable effect in terms of the improvements, so prolonged effects. We wanted to understand the movement-related contributions to the outcomes, so we got laboratory measures, but now the measures were of movement during function rather than measuring movement during clinical tests, which is typical in many clinical trials. We also looked at this not only immediately post-treatment to see if there was a change in performance, but also if there were durable effects, which would provide some evidence of learning to move differently. And then in addition, we wanted to prolong the effects of treatment. So in the prior trial, we had a deterioration from 6 to 12 months in function. So we decided to test the effect of a booster treatment for both exercise conditions. So people in strength and flexibility were randomized at 6 months to a booster treatment or a no booster treatment. And the same was true for motor skill training. We also wanted to get a better estimate of the outcomes. As I showed you, the course of back pain for many people is not just rapid recovery, but rather can be highly varied. And so we got measures, not just at 6 and 12 months now, but rather we got measures of self-reports on a monthly basis across the 12-month follow-up period. And then finally, we were interested in testing our hypotheses in a much more involved group than what we had tested in our early clinical trial. So the methods that were common to the two treatment conditions were that both groups received 6 one-hour sessions of motor training. One was strength and flexibility exercise, the other was motor skill training based on learning principles. The second was that clinicians were trained in standardized criteria for prescription and progression of the treatments. The prescription included no more than 3 exercises or activities per session, and we did this very purposefully so that people could understand what they were learning during a session and then carry through with it when they were outside of the session. We provided home programs with handouts. They were developed initially and progressed across the active treatment phase, and then all were encouraged to adhere across the active treatment sessions as well as at discharge. So there were 2 components to the 2 treatment conditions, strength and flexibility. We had education that educated people about the natural history of low back pain as a rather positive history. Also the benefits of exercise and activity to a person's back pain condition. And we told people that doing their exercises would improve their function. Exercise was progressive, resistive, lower trunk and lower limb strengthening exercises, as well as trunk and lower limb flexibility exercises performed in all planes, rather than targeting the planes of movement for which impairments were identified. ACSM guidelines were followed for progressive loading and progressive stretching that was performed 3 to 4 times a week. And we did not use an increase in symptoms during exercise to guide prescription or progression. Motor skill training was challenging practice to change person-specific impairment patterns during performance of functional activities without an increase in symptoms. So people were subgrouped based on the primary movement and postural impairments that were identified during the clinical examination. And then they were provided specific conditions to maximize the adaptations that are associated with learning. And so it wasn't just rote practice as in our earlier clinical trial. And so this isn't any different than trying to provide specific conditions to maximize adaptations for strength and endurance. Now we were giving them conditions that were now to maximize learning. So skill training was based on learning principles, as I mentioned already. These are pictures of extremes of someone who would have a primary flexion related impairment. However, people displayed flexion, extension, lateral bending, and rotation impairments in our sample. The education emphasized the repeated use of the impairment patterns to the person's low back pain course. And the training was to change their patterns during back pain limited activities. And there are 5 key components of the training that I'm going to briefly describe for you. The first is that the participant selected the activities that they were going to practice in order to get them engaged in the treatment and to keep them motivated. The participant was encouraged continually to problem solve so that they were able to follow through with what they were learning in treatment outside of the treatment period. During treatment, the clinicians were to minimize the extrinsic feedback, such as tactile, verbal, and visual feedback, once the person appeared to understand the principles of the impairment pattern that predominated their clinical presentation. And then the patients were encouraged to use intrinsic feedback as quickly as possible so that they could modify the patterns on their own, both within the session, but also be able to do it outside of the session. And importantly, the difficulty of the practice was continuously graded, not just across sessions, but also within. So if a person was working on coming from sit to stand without increasing their symptoms, and they showed that they could do that independently at a certain level of difficulty, it was then graded up within that session so that the person was constantly challenged to do something new and to learn to do it in a different way. So the activities range from very simple to complex, and we focused on work, leisure, and sport activities, again, individualized to the person's needs. The overall guidelines to address the person's specific impairment patterns included moving the lumbar region later and less. So they were cued to use trunk muscles that were needed to facilitate the appropriate movement or posture that we were encouraging. They were to move other regions earlier and more. They were to avoid prolonged end range spinal loading related to their impairment pattern. And they were to modify their impairment patterns without an increase in back pain. So they could have back pain, but it wasn't to increase. And that was their goal in learning to modify the impairment patterns. So prescription consisted of practice of specific activities 1 to 2 times a day, 10 to 15 repetitions. But importantly, the emphasis was on incorporating principles into performance of all activities across the day. So generalization, in this case, the generalization should be to optimize their back pain condition rather than to contribute to its ongoing course. So 149 participants received treatment, and the characteristics are similar to what I described earlier. I'm highlighting 3 of the characteristics just to show that indeed the people in this clinical trial were much more involved than in our prior trial. So average pain and worst pain over the prior 7 days was 5 and 7 now, and Oswestry scores was, the average Oswestry score was 32 and 33% compared to the 22%, which is quite high considering that these people do not have acute low back pain. So again, our primary outcome for this study was the modified Oswestry questionnaire. And this was an intention to treat analysis where we controlled for baseline Oswestry, sex, age, and duration. And the data I'm showing you is collapsed across booster, no booster condition because the boosters did not have an impact on either the primary outcome or the secondary outcomes other than adherence. So this is data during the active treatment phase. And what you see is that during this phase, function based on the Oswestry improved more and faster for the skill training group than for strength and flexibility. And so what you see is modified Oswestry score on the Y and treatment week on the X-axis. The data in blue is for the skill training group, and the data in red is for the strength and flexibility group. And what you can see is that at the beginning of the study, the groups were equivalent with regard to their functional limitations. And that over time, strength and flexibility improved 35%, so a clinically important amount. However, motor skill training improved 60%, almost twice what that of strength and flexibility. And they started to separate at the beginning of the 3rd clinical treatment. So, and from then on, skill training moved at a faster rate of improvement. At the second laboratory visit, the standardized mean difference between Oswestry scores for the 2 conditions was 0.85, which is a large effect. Across the 12-month follow-up, the gains made in treatment were maintained. So again, it's Oswestry score and follow-up of month. And what you see is that the average difference across the 12 months between the 2 treatment conditions is 7 points, which is above a clinically important difference between the groups. And the standardized mean difference at that 12-month time point was 0.58, which is a moderate effect size. So this is data from the current trial and the prior trial. So I can highlight kind of the big differences in findings between the 2 groups. So you have Oswestry on the Y and time on the X. And at the beginning, you can see that the groups are quite different in terms of their amount of limitation, with the current trial having much higher functional limitation than our earlier trial. You get a 60% improvement in Oswestry scores in the 6-week active treatment phase for the skill training, and it takes 6 months to get 65% improvement in the prior trial. There's a 63% improvement that's maintained across the 12 months in the current trial, and there's a 20% regression in the last 6 to 12 month period in our prior trial. So our hypotheses were supported with regard to what we expected compared to our prior trial. I'm going to show you a little bit of data regarding movement during function. I'm going to show you data from what we're calling a pick up an object test. This was a secondary outcome. And this is a very simple test where people pick up a lightweight object that's set in mid-range. So it's about set at knee height and about a distance away from the person of half the trunk length. So it's standardized to the person's anthropometrics. And all they're told is to pick up the object and return to the standing position. And we use something simple like this because this is a movement that people perform on a regular basis. People tend to perform functional activities in early and mid ranges rather than end range. So we're very interested in something very simple rather than something pretty strenuous, such as going down to the floor to pick up a heavy object. So I'm going to show you an example of impairment during the pick up an object test. On the left is back healthy control, and on the right is a person with chronic low back pain. And we put reflective markers on the person and then capture their movement during the test using these markers and calculating kinematics. And so we have markers on the lower shank, on the femur, on the trunk, and on the lumbar spine. And so you'll want to pay attention to what's going on in the lumbar spine, the hips, and the knees during the pick up an object test. And so what you'll see with the back healthy control is a lot of early and hip flexion and knee flexion with very little lumbar movement across the range of motion. On the right, you see a very opposite pattern. There's early motion of the lumbar spine, very little hip motion, and it's late in the descent phase, and no knee flexion in this particular patient. So this would be an impairment pattern during this functional activity. So now I'm going to show you 3 different graphs. I'm going to start with lumbar extension, and then I'll show you hip and knee excursion. On the y-axis, you see early lumbar excursion, and then 3 time points: baseline, post-treatment, and follow-up. And we look at, we define early as the first 50% of the descent phase, because we're interested, again, in how quickly does the lumbar region move compared to other joints that can contribute to the movement goal. And so you see here, data in black is for the skill training group, data in red is for our strength and flexibility group. And importantly, the groups start out the same at the beginning of the trial before treatment. Immediately post-treatment, the motor skill training group has reduced their early lumbar excursion, so that's an improvement, and it's maintained out to 6 months. Whereas a strength and flexibility group, there are no differences across the time points for that group, and it's significantly different at the post-treatment and follow-up. And so this idea of getting a sustained effect, again, at 6 months is our way of providing some evidence of learning, because it's after the active treatment phase and for a prolonged period. Hip excursion and knee excursion, the predicted effect would be that it would increase if the person was learning to improve their movement pattern. So you have early hip excursion on the Y, and again, time on the X. And what you see is that the groups are the same at baseline for hip excursion, and then the motor skill training increases a rather large amount immediately post-treatment, and it's sustained, whereas there's no differences across the time points for strength and flexibility. And you see a similar pattern for early knee excursion. The groups are the same. The skill training group increases their early knee excursion and maintains it, again, a sustained effect, and no change across time for the strength and flexibility group. So there were other secondary outcomes that favored skill training over strength and flexibility. I've listed post-treatment, satisfaction with care, average and worst pain, use of back pain related medication, physical function, absenteeism, and fear avoidance related to work activities. At 6 and 12 months, the frequency and the duration of back pain acute flare-ups were reduced, average and worst pain was reduced, and adherence was greater for motor skill training compared to strength and flexibility. And then finally, just a little bit about booster effects. We did provide booster treatments at 6 months to half of the participants in each of the treatment conditions, and boosters did not have an effect on any outcomes other than adherence, and it was only for strength and flexibility. So here you see the booster sessions over the follow-up, the 12-month follow-up phase with adherence on the Y and time on the X. The data in red is for strength and flexibility group who did not receive boosters. The data in blue is for the motor skill training group who did not receive boosters. And so what you see is then in green here is that the motor skill training group that received boosters got a little bit of an increase in adherence, but it's not significantly different from the group who did not get boosters. However, for strength and flexibility, there's a decrease in adherence for the group that does not receive boosters, whereas there's a slight increase in adherence to those who did receive boosters. So if you're going to provide boosters, you'll see an improvement in adherence. So if you want somebody to continue to do what you prescribed early on, then a booster might be important for strength and flexibility. So now I'm going to talk briefly about the relevance of the findings with regard to this person-specific motor skill training, and talk about why it might be important for clinical practice. So one thing that we think is important about motor skill training is that it appears to be more effective at improving function in the short and the long term. So I've shown you that skill training provides larger effects more quickly than a frequently prescribed exercise, a strength and flexibility exercise. And this was more and faster improvement during the treatment phase and durable effects during the follow-up phase. Motor skill training also appears to provide a more direct approach to behaviors that are proposed to contribute to the person's current presentation as well as their course. So it targets the impairment patterns during back pain limited functional limitations, and the training can be initiated immediately. So it's scaled, it can be scaled to any level of function at the first visit. So this may be a more efficient treatment for improving outcomes in people with chronic low back pain. And finally, motor skill training may provide a way to self-manage the condition. People can practice the activities across the day so they get a high dose of the treatment, which may facilitate maintenance of the gains that are made in the active treatment phase during the follow-up phase. And finally, I have here, it may be important for people who are non-exercisers, because many of the people who come into clinical practice are not regular exercisers. And so if the person can buy into this kind of a treatment, you'll find that they're able to practice this during their day. And again, this may facilitate maintenance of the gains without them having to do a formal exercise treatment. So the take-home message is if the goal is to facilitate learning or relearning of motor behaviors to improve function, then we need to provide conditions to facilitate the adaptations that are associated with learning into specific treatment of function. And if you think about the active exercise-based treatment options for musculoskeletal pain conditions that we use in practice, we often prescribe strength and flexibility and endurance training using parameters based on the evidence. And people typically will adhere to that, particularly if they're improving in terms of their functional presentation. But I think our data really suggests that we also need to be considering learning. There is evidence to guide this kind of treatment, and the data from this trial suggests that when someone needs to learn how to change how they're moving and postures that they're assuming across the day, we need to give the correct stimulus in order to get that effect. So I've acknowledged my funding sources across the slides, but I'd like to acknowledge the specific people who contributed to our recent clinical trial, and also all of the people who contributed to all of the prior studies that led to this trial. So thanks very much, and I'm happy to take questions. So Amy, should I stop sharing?
That's fine. Thank you very much, Linda.
Sure.
So there was a question that came up in the chat from Damian Howe, and his question was related to the motor learning concepts that you used, and something around the effect of like external cueing or feedback was used before weaning towards internal focus for cueing and feedback. So I think some more specifics on maybe the motor learning concepts that you use may be helpful.
Well, so basically the idea is that what we typically do, which is give extrinsic feedback, and we give it a lot and we give it across multiple treatment sessions. The idea is to give the person enough so they understand what they need to do. And you can do that again by verbal, tactile or visual kinds of cues that we often use in treatment, but then ask them what they're feeling during performance of whatever the activity is, and giving them the ability to try out different strategies to see if they can figure out if indeed they are doing the activity, modifying the activity appropriately. So it's a lot of trial and error, because learning doesn't occur without making errors and then figuring out that you've made the error and using whatever feedback you can within yourself to let you know that you've made that error. So hopefully that helps.
Damian, let us know if that doesn't. Anyone else have questions?
Must have been really straightforward, huh?
This is Damian. I've unmuted. Can you hear me?
Yes.
You're using the terms intrinsic and extrinsic, and I'm thinking external focus and internal focus
And can
terminology.
You describe, okay, and can you describe what you mean by that?
External focus is a cue or feedback or prompt that's external to the body, whereas a cue that's internal to the body. So an internal cue would be move your hip joint backwards, and an external focus would be have your butt touch the wall when you bend forward. That's external to the body.
So that I think we're using them somewhat similarly. So so the external would be, perhaps for us, it would be hands-on to let them know that they've moved far enough. The internal would be, particularly early on in this kind of a treatment, would be a person's pain behavior. What does it feel like? Are you reproducing your symptoms? What do you think about that? Is there something you can do to change that might change those symptoms? Other things people have used is, oh, I feel stretching now, and you can ask them, is that your pain or is that just stretching? And if they can distinguish the differences, but those would be that would be their intrinsic feedback. So I think it's similar.
It's similar, and I just thoroughly commend you for doing this work. I would suggest, as we all struggle with the motor learning concepts, that we consider the timing of the external focus, internal focus, and individualize if we can, because some patients are going to need an auditory feedback, some are going to need a visual, and some are going to do better with a tactile kinesthetic. And as we get our library of cues developed, we'll all be better.
Sure. We just had a discussion of this, that it is really individualized as to what people respond to. And then the big deal is, from our perspective, is that whatever helps them to understand how they're moving or the postures they're assuming that seem to contribute to their symptom behavior, whatever cues that takes, so that they understand that concept, and then starting to take away those external cues so that they can start learning to use something other than you or me telling them what to do.
Great. We have another question. Jennifer, do you want to, I'll go ahead and read it. Jennifer Zellers is asking, what are your thoughts on the combination of motor training and exercise or other intervention? I'm wondering about the capacity question. Is there a role for strengthening if a patient doesn't have the ability to adopt a more adaptive motor plan?
Sure, that's a really good question, and a question that's come up. And so we thought that would be the issue, that perhaps there's going to be a certain kind of patient that doesn't respond to this immediately, and that they're going to have the capacity in order to do the activity. And interestingly and surprisingly, that was not the case. The clinicians, I did not do this, the clinicians were able to scale down the function, the activity that the person needed to work on, to a level that they could do it without having to lie down, for a week or two and do just your traditional therapeutic exercise. They were cued during the activities as to what muscle groups they might want to use, so that they could attain the optimal, for lack of a better word, optimal movement or posture. And a lot of, again, I didn't treat, but based on the clinicians giving me feedback, the patients came back reporting soreness in muscles that they had never used before, kind of like an exercise effect. We did not measure muscle strength or muscle activation because the protocol was just long as it was. What we do know is that everyone progressed in both conditions in terms of the number of activities and the difficulty of the activities, suggesting that their capacity is improving. There's also some work by Gretchen Salsic, and I think Marcy Harris-Hayes also has some, where they did something similar to this, did not target strengthening, but yet there was a change in muscle strength pre to post treatment, an active treatment phase. So we thought that there would be a capacity issue, and there was not for the kinds of patients that we saw.
Great. Linda, I'm excited that we actually have evidence that the skill that we use as physical therapists to evaluate how someone moves is beneficial. So I guess one piece that was really important, and I think I'd like to get a little bit more information was, you talked about the screening tools that you used to identify that these were nociceptive pain patterns, the predominant nociceptive pain. And I think that's an important factor when we treat patients. So can you talk about the screening tools that you used and the clinical exam test, just so that we have a little bit more detail?
Sure. So it's a standardized examination we've used, and it's not different. We look at active trunk movements in several different positions: standing, sitting, supine, side lying, prone, and quadruped, and also limb movements. And you look again at how quickly is the back moving versus the limb, and what the symptom behavior is that's associated with that. And I think that what's really important is this idea of, if you see a pattern across tests of early lumbopelvic rotation, and you then systematically change that. So they do the clinical test again. So the example I showed was hip lateral rotation. They do the test where you systematically modify it so that they're not moving in the lumbopelvic region, and you see if that changes their symptoms. So it's this idea of looking at this pattern of lumbar region movement across a series of tests. If you see an impairment, and we have specific criteria for that, and you systematically change it and the symptoms improve, that's what tells you whether those movement impairments are important to the person's current presentation. And then we do capture pain catastrophizing, fear avoidance, mental health kinds of measures. So things that would tell you that there's other factors that may be contributing to what someone looks like.
Mm-hmm.
Does that help?
Yeah, perfect. So we have another question from James Williamson. What's the next step for research? Is there room for improvement in the teaching of motor control or in the dosage?
Yeah, that's a great question. And we're planning a grant currently to, again, work with people with chronic non-specific low back pain. And so one thought is, so we did this, we simulated situations that people were faced with at work and at home. And so anything somebody had to do, we built or bought the prop that the person needed. We had rooms set up that looked like kitchen, workstation, and a bedroom. And so we got these nice effects. We think that it might be more important just to go to a person's work situation or their home situation and do it to their very specific circumstances in order to get, I think, we're hoping to get a faster effect and even a larger effect, get people down to 0. So the average Swestry score at the end of the active treatment phase was 10. So we're thinking we can get even better and perhaps change the number of sessions based on the rate of response, so that some people may need more than other people, is another important question. We're really also interested in how do clinicians learn to do this, and what are the barriers to that? What are clinical barriers to this kind of treatment? This is an hour of working with someone. It's 45 minutes of activity and then also education, about 15 minutes. So it's a lot of time. But the question really is, if you do this, how is their course so much better that they don't come back as frequently? So the cost effectiveness is in the long-term payoff. So those are some of the things. Those are the things we're proposing to look at as the next step. People have suggested also to combine strength and flexibility with skill training. Maybe that's also could be important.
I can imagine there's lots of avenues to go from here. So I think it's just, there are a lot of options, and what's your next choice, I guess, is what the decisions that you're making. All right. If there's no more questions, I'm going to wrap it up. Thank you, Dr. Van Dillen, for an excellent study, an excellent presentation, and congratulations on being the Rose Award recipient.
Thanks. Thanks very much. It's great. Thank you.